except we're going to use the sacrum, not the ilium. In this case, the lesion side is down. All right? So this is the lesion side. The patient is laying on it. By laying on it, again, that ilium of the involved side is locked out and taken out of the equation. The position for the patient, for the most part, is the same in the side-lying position, except their femur is in as much flexion as possible, or as is relatively comfortable. What that does is it takes the upside sacroiliac joint, puts it into flexion, and basically locks it out. So it's not moving either. Again, you want to be as specific as possible to an individual joint. So your contact is going to be on the contralateral diagonal inferior lateral angle of the sacrum. So this is, the lesion is here, your contact is up here. Okay? It's a little bit like a seesaw. You guys all know how seesaws work? Mm-hmm. Diagonal seesaw. So when the patient is in this position, the lesion is on the table, you find the upside PSIS. I'll come and show you over there for your camera. So once you find that upside PSIS, your hand just slides down like that, and your pisiform just ends up where it needs to be on the sacrum. You palpate and find the upside PSIS. Your hand just slides in there, and then you're on that inferior lateral angle of the upside sacrum, which is contralateral and diagonal to the lesion. Okay? And then when you make your correction, because the upside ilium and femur is in as much flexion as possible, what we're trying to do, and this is called the scoop move. So its official name is the sacral counternutation release technique. Because in the lesion, if the ilium is stuck in flexion, what has the sacrum done? If the ilium is stuck in flexion, what is the sacrum stuck in? Nutation. Remember, when the ilium goes into posterior rotation or flexion, the corresponding sacrum nutates. So the ilium does this, the sacrum does that. So to correct it, what would you do? You would counter-nutate the sacrum. Therefore, it's called the sacral counternutation release technique. It is also known affectionately as the scoop move. The scoop move is because your contact being on that upside contralateral diagonal sacrum is you're going to, as the person is in flexion like that, you make your correction, you're going to scoop. Push this way, so on that seesaw theory, the lesion sacrum is going to counternutate. Okay? This is a more difficult setup, technically speaking. The iliac extension release technique is easier, technically speaking, but there may be circumstances in which you feel like it's the sacrum that I need to mobilize more than it is the ilium. So then this way you have the option to mobilize the sacrum and or the ilium. Okay? So what that looks like, can I have somebody up here?
Have to be me again.
All right. All right, scoot a little closer to this edge. And sometimes I'll tap on the edge that I want them to scoot closer to, so they'll get it. Because I might say scoot closer to this edge, and they're like, they start going a different direction. So I'm like, just scoot a little bit closer to this edge. They do that. Scoot a little closer to that edge. There you go. Again, get the patient set up. Now, even though somebody is used to treatment, and they come into your office and you tell them to get in, assume the position, you're always going to want to just do the fine-tuning. It's kind of like if somebody puts on a jacket for you or a hat, don't you always just kind of do this yourself, just to make sure everything's just perfect? So you want to do that as well. So now, the lesion is on the table. Even so, I am still going to run through this procedure just to feel the PSIS, because it gives me a sense of mobility, it keeps the choreography consistent, and like that. But I'm not really doing it because I'm not assessing that particular sacroiliac joint. I'm just kind of doing it for routine. All right. But now what I'm going to do is I'm going to put the patient into flexion. So you can see Tricia is in about as much flexion as she can comfortably take. So the upside sacroiliac joint is locked up. And so I'm going to find that upside PSIS, and again, my hand is just going to slide in, and it's going to be right there on that inferior lateral angle of the sacrum. And in this case, my contact is more on the tibia, because when I make my genuflexion and my thrust, it's going to make the leg go a little bit more into flexion. So that's going to facilitate the movement that way to help assist the scoop. So what that looks like. Sometimes the leg starts to come off more this way. I can push it back a little bit. Sometimes you can ask the patient to bend their leg a little bit like that, because that gives the patient a little bit more sense that they're on the table. Or as you've already discovered, you can ask the patient just to hold on to the side. Again, in clinic I wouldn't do that necessarily. You should be past that, but this is like training wheels. Okay? And then boom, down like that. So this one, you want to have that contact on the tibia, because when you make your thrust, you are going to get more of that femur into flexion. Whereas with iliac extension, you want it to stay that way, so that when it goes this way, it stays theoretically in extension, right? You all got that? So in this move, you want to create correction where it goes more like this. Where the first one, you want to keep it where it stays in that relative position, in that relative vector, right? Okay, so let me just do it on the other side, so you guys can see what it looks like back here. Face it this way. A little bit closer to this edge. Very good. Bring your top leg up, bottom leg is straight. So again, I'm just getting the position, patient into the right position, because you want to avoid artifact of bad positioning. Find that upside PSIS just for the hell of it. Flexion up, find that. This hand just kind of slides in there. And then boom, down you go. So we'll practice that up. As I mentioned, there's also a kick move, but we're going to do that next lab.